Thank you,
Yes.
Dr. Lowe. Thank you, everybody. Thank you for organizing this really wonderful meeting and really wonderful effort to, um, well, collect all expertise, um, aspirations, and everything. But beyond everything, it's a collection of love and compassion that manifests in various things, and I really really appreciate, and on behalf of myself and of course on behalf of uh, my ALS families in Indonesia, but without further ado, if I may share um, a little bit of how things are in Indonesia. So may I share screen at the moment? Right. So I put together a few slides just to give you an idea of how things are in Indonesia. I present to you something which is a little more formal, uh, which is the ALS uh, Indonesia Foundation, and foundation is Yayasan in Indonesian language, so it's Yayasan ALS Indonesia. Uh, it it started with a personal concern actually. Um, when I was diagnosed about 10 years ago, so I'm a rather long-lived ALS patient, perhaps an outlier. But when I was diagnosed then, I didn't have any idea what ALS is, motor neuron disease, and everything. Um, Strangely enough, uh, I am in the same profession uh, as the late Professor Stephen Hawking. We're both cosmologists, physicists, and I knew he's got something uh, of neurological disease, which you know uh, was progressive for him then. Um, but I didn't know more than that. But then when I Googled and started to find information, and I was really uh, shocked how how devastating it could be. And the more shocking for me was the numbers here, the statistics that was quoted um, then was the incidence and the prevalence. Of course, it's still called a rare disease, but if you see this number and you multiply by the number of population in Indonesia, at least do the you just take the numbers, which is perhaps more of the uh, average people having ALS, above 50 or something like that, you still get a high number. It could be in the tens of hundreds of thousands
Meeting
patients
up.
in Indonesia. So I was wondering, where are they? Where are the rest of ALS patients in Indonesia? And how come there was no information on ALS in Indonesian language whatsoever? So I wasn't worried about myself, but I worried about all these people. Where are they? How come we never heard of this? So therefore, I started to collect more information, learn about ALS, and then thought, we need to find ways to identify other people with ALS, their families, etc. Mm, getting their stories and find out where they are in Indonesia. So this is the map of Indonesia, of course, but I put numbers. Pretty much, this is something that we need to update every now and again. But the numbers are those registered with us. So most of them, of course, are in Java because that's the way we diagnose, or the hospital, the doctors, and the convenient way people communicate. It doesn't mean that there are less people with ALS on the other islands. It's just that the way we identify them, how they could get themselves diagnosed is a lot less uh, uh, of a success compared to those in Java, for example. Um, so with that, we try to have a collaboration with medical professionals, and we got to know Dr. Sheila, Dr. Yovita, and more doctors in big cities in Indonesia. In Bandung, there are Dr. Regi, Dr. Chandra, Dr. Nani, and we put together a seminar, the first one, a seminar on ALS for public, and it was well attended. I was really, really touched, and by then we learned of other fellow patients and how they've been living, their families, and also other people who are not related to ALS, don't have anybody with ALS in their families, but uh, are concerned, want to support. But of course, by that time, we don't know uh, we don't know how we are, and so that's uh, uh, it shows you how also we don't know how people could support us. So it's something of a new revelation that we actually could use a lot of support, a various kind of support, not just medical support, but living support and social support, etc. So with all these, and then more of because of that public seminar, some people who work in journalism took interest, and our stories appeared in papers. We were invited to give talks, etc. Um, so the awareness of ALS was increasing, not only among uh, the public at large, but I think more importantly among medical professionals in Indonesia. It's very interesting, to say the least, how unknown MND was, even among medical professionals. Um, so with that, with the support, with um, it's it's not just support, I would say, but it's a commitment of some of our really, really, really good friends, doctors, patients' families, and um, friends from other professions, people who work in the legal area, who help us on how to establish a foundation. I didn't know anything about that. I didn't know anything about how to put together a foundation. What um, form would best um, manifest the support for ALS community? Would an association be good? What is the difference between association and foundation? All those things, and then we learn from this uh, alliance of ALS association, a various form of association. The more important is what is it that we're trying to achieve. Um, so with that, any kind of form would actually be okay, but also we need to have our uh, formation uh, established legally. So foundation was perhaps the best that we could think of. So there we are, established in 2015, and we decided that our uh, area of concentration was on the social and humanitarian aspects in the caring of ALS patients. And of course, by that, we would be working with medical doctors who who take care of the uh, technicalities, etc. Um, but it's uh, along the way we understand the nitty gritty of it, and we are still learning. And our vision is that ALS patient would maintain the best life quality they could get, as long as they could hang on to life. And of course, for that is to have a better understanding of what motor neuron disease is, that it is a progressive one, and all the living challenges that goes along with it. Um, the foundation itself is uh, is in Jakarta, and we've been getting beautiful support from the Mayapada Hospital in Jakarta Selatan. They um, kindly provide us with office and meeting rooms whenever we need. And some of our doctors are practicing there, and it's just it's something that I really could not imagine before, how supportive people could be if they know how they could support. And for us, it's also something which very encouraging to just to work with them bit by bit. And the foundation is chaired by me, and Dr. Sheila Agustini is also our neurologist, is uh, s- positioning herself as the vice chair, and she's been really, really indispensable in various aspects of our foundation. I'm fully in depth to Dr. Sheila for all the things that's been dedicating herself into our cause. Um, just to give you an idea of how we're still learning, is that how we put together our program, and all the activities that we could still put together, is the most important is to communicate with relevant medical professionals, to identify um, fellow patients and how to get in touch with them. This is crucial, um, to know where are the other patients. The first two slides that I had shown you, it is one of the challenges finding them. Indonesia is a huge country, and very diverse in the culture, and therefore the way people communicate, and of course very large spectrum as the uh, level of a quality of health service. So therefore, there's no guarantee that people who might have a motor neuron disease has access to the right path to diagnose. So to work together with doctors is really the main key. And also we try to hold meetings with our fellow patients and caregiver, and it consists of number one, to get to know each other. So it's really socializing and knowing that we're in the same boat more or less, and sharing everyone's challenges and successes in caring. And of course, we need to now and again and again, introduce what ALS is, what has been known as the disease. This is uh, a developing situation. It's we don't have a full understanding of this disease, and therefore, the challenge in finding cure is still there, and just training on basic caring, especially for those who have their family caring for them at home. And we try to also hold public seminars again to raise awareness, and also um, co-hosting professional seminar, uh, uh, partnering with medical school or groups of medical professionals. But what's most active is our um, electronic communication. In our WhatsApp group, we've got 125 members as of today, and it consists of patients and families and medical professionals, and I can tell you that I'm really touched how people, our friends, stay in our WhatsApp group, even though they're the the member of their family who had ALS had passed away some time ago. They're still with us because they still want to share, they still want to support, and we are family more than anything. So I'm sorry, this is rather emotional. And we also try, not yet successful, just raising awareness and fun, because our fellow patient, they have various kind of challenges that we need to address and we need to help, and often we're not there yet. So we still work hard for that. But every now and then we've got emergency situation that needs quick assistance from the medical professionals, and so what we do is just coordinate communications, and uh, we know that it is very important that we are there for them, not always finding solutions, but to coordinate communication is something which, as a start, is a support for them. As here are some pictures, number of our meetings and what we do, and I'm just showing you, perhaps irrelevant, uh, but this is something that I went through in learning how to organize a forum like this. This is the ALS Therapy Development Institute in Boston. They had annual meeting back then, and I think they're rather uh, busy adapting to this COVID situation. But I learned from their how they build their support system, how they do their networking, how they do their fundraising, etc. Of course, they have a different setup in the US, but still, it's always something that we learn. It's just the spirit is just so wonderful. Here are more of our meetings. This is our professional meeting. Here is Dr. Lowe, here's Professor Martina, and so it's this Dr. Sheila and Dr. Yuda. This is the first medical professional meeting on ALS that we co-hosted. And this is, I don't know whether you remember, this is a few years ago. We had this gathering in Kuala Lumpur, which is really nice. Um, we try to have things also in the documentation. So everything about the foundation we put together in our website. Also, stuff that we put together as far as videos and things, making sure that they're easily accessible. Also, Dr. Sheila and Dr. Law put together this beautiful book, and we provide them for free, and some of them we sent printouts for them, for those of them who have problem accessing online resources. And they're just easy brochures that we could send out to people using WhatsApp or social media. And networking with you, of course, really, really invaluable. And working with the Society of Neurologists in Indonesia and the PACTALs, the International Alliance that I had mentioned, and ALS-TDI. Um, I think something like this, uh, as Dr. Lowe mentioned before, we are all equal. But after all, really, some are more equal than others in the sense that you have started something earlier, you've got more people. I don't know, in science, we have something that we call critical mass. And I think you passed that critical mass, that the threshold is such that you could progress um, significantly. And we're not there yet. And I think this is something that we need to uh, to get your help, how to uh, pass this threshold is such that, number of people having the right expertise, the number of people who could work together for raising awareness, etc. So I think there are more patients in the country, in our country, because we've got bigger population by far. But as far as the other parts, the other elements of the caring, we are not there yet. So I think that is something that we try to um, pursue here, is meeting that critical mass, meeting that passing that threshold to get things going with the with with enough momentum to build something with a significant impact. So I'll end there. Thank you really, really very much for everything. Thank you, Dr. Law.
So, Dr. Low and Dr. Premana, I'm here together with some of my colleagues. I'm very grateful. We are very grateful to be invited, and we have no financial disclosures. Singapore is a very small island. This is where I work. This building just has a Tan Tock Seng logo. This is our founder from the 19th century. He was a poor migrant who became rich, and then he gave back to society. So we hope to live up to his vision. The other partner you do not see here is National Neuroscience Institute, NNI. So the Tan Tock Seng Hospital used to be one of the biggest neurology hospitals in Singapore, but NNI has grown beyond us. It's a national entity, but so they cover most of the public hospitals in Singapore, but we work very closely with all the NNI colleagues. So I'm an anesthetist and intensive care specialist, and therefore I will not be touching too much on the neurology aspects of ALS, but I'll be sharing a lot more about breathing support. So this is Dr. Bjorn Ibsen. He's a Danish anesthetist. I look up to him a lot. So he came back from the US with skills about how to help people to breathe. And Denmark had a terrible polio epidemic, and because of that, he introduced a new technique. They ran out of iron lungs. So in those days, people would go into a chamber, a vacuum would help to move the air in and out of the lungs and help them to breathe, but they ran out of iron lungs during the polio epidemic. So Dr. Bjorn Ibsen recruited medical students. They put breathing tubes in the polio patients, and medical students took turns to hand ventilate them. And because of this heroic effort, Denmark and the rest of Europe turned the polio epidemic around. Currently, we are going through COVID. It's a different disease. And because of COVID, all the other chronic diseases like ALS and all the other diseases are taking a back seat. But we know there's a lot of disease burden and a lot of suffering due to ALS. So we do not want to forget that even as we battle COVID. So the story of ventilation in Singapore is that Singapore was a third world country. So when polio ravaged the world, there's no choice. We just let our people die. I think like Dr. Premana says, in Indonesia now, you may not realize that there are ALS patients. So in those days, we didn't, our polio people who didn't have access to healthcare would just pass away. Currently in Singapore, we probably are not catching all our ALS patients, because if the prevalence is 5 per 100,000, we have a 5 million population, so we should be seeing about quite a sizable number, but we are not seeing all of them. So there might be some poorer people who are still not diagnosed. Singapore is now a richer country. The government is interested in looking after the people, and therefore there are technologies and treatments that prolong the life. I will be touching on this over the next few sessions, but every technology that prolongs life means that you have to confront the suffering that comes with the disease. Okay, I separate the two because some of us doctors are very skeptical. Some doctors are very negative and they use the word prolonged dying. I think that is an insult. Okay, so from the beginning of history, doctors have always tried to prolong life. Nobody wants to suffer. So what comes with prolonged life is that if you cannot get rid of the disease, there is suffering. So as a doctor, I have to understand this. So I do not recommend all treatments possible to prolong life if I think overall in the equation, it increases suffering. But to be very negative and say that treatment prolongs death, treatment causes suffering, we will never progress, right? So I come from a background where we are more technical, more professional. The government and the hospital is very concerned about dollars and cents and about efficiency. So when I hear Dr. Premana talk about the movement in Indonesia, I'm very touched, because ultimately we are facing a disease that currently still has no cure. And I know when I talk to each patient and their family that they want to live 1 day longer or 1 week longer, but they also know that each day or week that they live longer, there is suffering. So I think there are things that medicine can do to decrease the symptom burden, but some of the suffering cannot be taken away. But some of the suffering can be transformed by love. And so I'm very touched when I see how the Indonesians, and I saw it in Malaysia too when we went to Dr. Loh Chin's unit, how the families, the volunteers come together to support each other. And this is something that I think Singapore, we are very privileged to plug into this Southeast Asian circuit. And then we will learn from our bigger brothers how to put a human touch to it, how not to be so concerned about dollars and cents, and to be worried that people will sue me as a doctor, but we help our patients. So this is the first patient. He doesn't have ALS. He was a spinal cord injured patient. He was in our ICU for a long time. He needed a breathing machine because he was paralyzed from neck down. And he was responsible for us starting long-term ventilation at home in Singapore, because essentially he had a young family and he hoped that we could help him live longer, and we had to figure out how to do it. But now I switch gears back to ALS. So ALS is not a new disease. It has been with us for thousands of years. But in 1874, a French neurologist neurologist Jean-Martin Charcot that discovered ALS. He was also a very compassionate and a very wise person. He says if you do not have a proven treatment for certain diseases, bide your time, but do not harm your patients. So I think like in the 19th century, I don't know whether they have moved away from bloodletting. I don't know what kind of treatments they use, but he realized that sometimes our treatments may cause more trouble, and therefore he gave this advice to his younger colleagues. Okay, if you look at who looks after a person with ALS in the first world countries, in the USA, maybe in UK or France, in um, centers in Singapore, you have so many professionals looking after. Do we do a good job? Imagine if each of us charges a few $100s for every consult. It will be unaffordable. You will go bankrupt before you live another year, right? So in the more socialist European countries, the government would pay for care and the government will coordinate. And of course, the government would have to ration. So the government cannot let you spend unlimited amounts of money. So they will put guidelines to say this is good, that is not good. Therefore, you can do this, but not that. In Singapore, we have a co-payment system. So the government pays some and the patient pays some. There are charities in Singapore, and therefore many of the good NNI doctors and nurses will be running for charity, raising funds, because we try to make the field equal for everybody. But my point of this slide is that this is not sustainable. We cannot have so many different people looking after the same patient. So what is the solution? My proposal is that we try to be transdisciplinary. That means if you are a family physician, you are a rehab doctor, you are a neurologist, you are an intensive care doctor or pulmonologist, you have to look beyond your narrow field and see what your other colleagues are doing, learn from each other and help our patients. Similarly, if you are physio, don't stop your nurse from helping with the secretion management. If you're a nurse, don't scream at your speech therapist because she is trying to pay attention to a wound, right? So we help each other. We are transdisciplinary. There will be patients who can afford to pay for a more specialized group. There will be some patients who can only see a small number of professionals. And each of the professionals looking after the ALS patients need to go beyond their narrow boundaries. There is also a disadvantage of a very, very broad base care provider professional system. None of them may understand the ALS patient properly because they see them from their own narrow angle. You remember the story of the elephant? Then the person who holds the trunk say the elephant is a hose. The person hold the tail say elephant is a rope. And then the person hold the leg say elephant is a tree. So that is the problem when all of us come and look at ALS like that. So I think the Indonesian approach where we start with the patient and the family, see their needs, and embrace it holistically will be better. Okay, I just give a few examples. I know that Dr. Lo's team has planned a whole series of education. I'm only going to cover the breathing, but today I'm supposed to help with the introduction. So I just assembled a few anecdotes. So these are like jigsaw puzzles of some of the patients I've seen over the years. And you'll see that ALS is really an elephant. It's a very strange creature. So we've had not uncommonly, we have patients who are elderly. Then they come in because of leg weakness or unsteadiness in gait. And if you are the GP, you think, okay, most of the people who are elderly have osteoarthritis. You refer them to orthopedic surgeon. Orthopedic surgeon do a knee x-ray, obviously there will be decreased joint space. You do an MRI, obviously there will be the wear and tear of the cartilage. So it is not wrong. The patient has osteoarthritis. The question is, did osteoarthritis cause the problem? So the orthopedic surgeon did a knee replacement. Then there's still problems, now suddenly, although the leg has got less pain, but now the arms are a bit weak. Then they do an MRI of the spine and find that there's cervical myelopathy, and then they go on and on and on. And then the clue that it might be ALS could be that there's a problem sleeping or there could be pneumonia. But if none of the doctors turn on their awareness about ALS, someone might be giving sleeping pills for insomnia. And then when they come in for pneumonia, the intensive care doctor or the pulmonologist may not be thinking about ALS. So raising the awareness about the disease through things like Ice Bucket Challenge, having public education, even for doctors, especially for doctors, is very important. So for Miss X, what would be of important focus to her would be a correct diagnostic journey. If she sees the correct neurologist, get the nerve conduction and muscle testing done. And once the diagnosis is done, she needs occupational therapy and physiotherapy focus to preserve her mobility and decrease the risk of falls. Then when she has got breathing issues and sleep issues, she needs to see a sleep and breathing specialist, right? So if you get her onto the correct journey, then she has a shortened journey. She doesn't have to go through knee surgery, neck surgery, and whatnot. And another typical presentation we have is maybe a fairly young person, and there's a change in voice. So they start to notice that their speech is not the same. Others will notice that they now have difficulty. So I had a patient tell me, used to love to eat wonton noodles, but he can't eat his favorite food. When he eats wonton noodles, he would choke and cough. So he learned that he has to switch to porridge. Some of them who progress faster may start to drool saliva and lose weight. But those who do not progress so fast, they may end up seeing a lot of ENT specialists for a long time. The ENT specialist will scope the throat, do all sorts of tests, and may not find anything. So again, the index of suspicion, so an ENT specialist will refer them to a neurologist, is very important. The different specialty doctors need to talk to each other. But usually by the time you have this plus drooling plus loss of weight, it is quite obvious. Not uncommonly, some of these patients are quite functional and strong. They can walk, they can transfer themselves independently and do things. So this group is very challenging because I will dwell on it later in some subsequent lectures. The vocal cords and the throat are the crossroad junction of our breathing and our swallowing. And so if this area is dysfunctional, unfortunately, life expectancy is a big issue. They need to think about how they want to live and whether they want to accept certain treatments. Okay. Then the treatment of the saliva and the treatment of speech and swallow is very challenging. This will need a fairly specialized kind of approach. So in our setting, we often work closely with the speech therapist as well as a neurologist on this. We know that maybe in the more rural areas of Malaysia and Indonesia, you may not have access to this. I hope that through this forum, we can raise awareness about some of these, and we can work around ways to help. So maybe within your own country, you can build the expertise to help these people. Some people with ALS just present with shortness of breath. So the marathoner became short of breath. The usual story you hear is that we cannot lie flat. When we lie flat, we have difficulty breathing. But it's not uncommon. I've seen at least 3 to 4 cases where they have shortness of breath standing up or sitting upright. And we call that platypnea in the medical term. And the reason I'll allude to later is that the breathing and the core support muscles actually work together. And when these muscles are weak, you will have problems. So this person needs breathing assessment and breathing support. Okay. Then lastly, we not uncommonly, even in Singapore these days, we have people who present as a pneumonia. So they present to a hospital with a pneumonia and then they are on breathing support. They cannot come off breathing support and they end up, and the diagnosis of ALS is made a few weeks later. So this still forms about 15 to 20% of our patients in Singapore. So for Jakarta, for KL, I think it's for the intensive care and the pulmonology doctors to recognize this and to realize that solving the ICU stay and solving the breathing is only a small part of the puzzle, because there are a lot of other issues to consider. Okay, so I'm not a neurologist, so I'm going to skip this, but essentially ALS affects the parts of the brain and spinal cord that control the motor neurons, the muscles, the nerves that control the muscles. So those from the brainstem area control the throat, the tongue, the vocal cords. We call them like bulbar function. That just refers to the appearance of the brainstem, looks like a bulb. Whereas those motor neurons that from the brain come down the spinal cord, affect the spinal muscles, and that tends to affect the trunk as well as the limbs. Okay, and then depending on whether it affects, there's usually two nerves and they join together at one interface. If it affects the upper nerve, the nerve from the brain, then they tend to have a certain pattern. If it affects the lower motor, they have a different pattern. I'll leave it to the neurologist to educate you on this because this is not in my element. Okay, as I mentioned, my main job is to look after the breathing support of the patients. But over the last 10 years, our team has helped to look after more than 100 ALS patients. And therefore, we do see that this seems to be the common needs of the motor neuron disease or ALS patients. The first, as I alluded to, is to find the diagnosis, avoid many detours that are unnecessary that increase the risk to the patient and increase the healthcare costs to the patient, right? Once you have made the diagnosis, currently there are about 4 drugs that are FDA approved that may slow the progression. So in Singapore, the common drugs that are considered are Riluzole and Edaverone. None of these 4 drugs are magic bullets, and the whether to use or not to use them, I think you need a discussion with an experienced neuromuscular neurologist to discuss whether it is helpful or not and in your context. Very importantly, once we know that you have muscle weakness, we need to avoid harms. So everybody wraps around to support, prevent falls. Surgery is a high risk thing for anyone with breathing problems, so unnecessary surgeries is out. Okay, preventing the next respiratory infection is very important. So simple advice like don't go to crowded places. Nowadays we talk about wearing masks. So maybe the person is so breathless, cannot wear a mask, but people around him or her can wear the mask. And then timely vaccination, so flu and pneumococcal vaccinations. COVID vaccination is still very early. We haven't vaccinated our ALS patients for COVID yet, and we do not know how they respond, but we will keep the group informed once that happens. Those patients, okay, there are 2 groups here with feeding issues. For some patients, they waste away even if their throat muscles are not involved because sometimes the muscles have a lot of fasciculations on it. So it is not uncommon that ALS patients lose a lot of weight, they become very tired. But those with direct bulbar involvement, they have a big problem. They can't chew and they can't swallow. They don't get enough calories. And of course, if your swallowing is so bad, every swallow could be your last. And therefore, figuring out how to support the feeding will be important. On this point, remember that artificial feeding is also a form of life support. It's a life-sustaining treatment. So in itself, it's a good thing. It may come with some concerns and considerations, and you need to decide whether to go on to life-sustaining treatment based on your own personal, family, economic, and social situation. So I think like as a doctor in a public hospital, I can just decide everybody gets a gastrostomy for tube feeding. But if this person has got no family and no one can look after him and he's going to stay in a nursing home and he's someone who values independence and who needs to socialize, and then now he's staying in a nursing home when nobody talks to him. Am I giving him a good option? So I think these are things that we will need to think about and discuss with the patient. There's no direct simple algorithm. Okay, we'll talk more about supporting breathing later and over the next few sessions. Um, Maintaining mobility, this is not my element. I hope some physiotherapists and some neurologists will help to talk about this. And then maintaining communication. We're grateful that one of our speech therapists will be coming in to share. I think the KL group has also done an excellent job using augmented or alternative communication. So I think both the Singapore and KL group can share their experiences with this. But essentially, we are thinking creatures. So are we like an animal? In a sense, we are animals, but in a sense, we are animals who have abstract thought. And what makes me unique, makes me Chan Yao is that I can think, I have formed opinions and judgments, I have got emotions that I can express. So I'm very irritated when I go to the ward and I see junior doctors or nurses treat the patients like a vegetable, you know, or a piece of wood. And they say this patient is uncommunicative. I say you do not know how to communicate. Most 99% of patients are communicative in a certain way. It's up to us, people around the poor patient, to figure out how to make the connection and to communicate, right? Okay, so this is to sell Koyo. Next few weeks or months, we will be covering neurology. So I think Dr. Sheila or other invited neurologists will be talking about this. Then I'll be dwelling about breathing over a few sessions. First, this is quite complex because you need to understand how we breathe, then how we clear the airway of secretions, and then the various ways to support the breathing, either through non-invasive natural airway or invasive. Um, so this is like a schema of how we breathe, and understanding some of these is important because a lot of doctors are greedy. We want the oxygen saturation to be very high, and that affects the acidity and the carbon dioxide in patients with muscle weakness, and so on and so forth. So we will cover this in future sessions. We will explain some of the tests that we do and what it means for the patient, and therefore how to interpret. So just for those of you who know, this is like a schema of our breathing um, physiology. So this is like what you are all doing now, breathing at tidal volume. Whereas if I'm doing a vital capacity breath, we'll be talking about the impact of the vital capacity on your baseline breathing, on your blood tests, and then also when you have disease or you have lung infections. So we'll cover that later. Okay, for those of you who are working in the acute hospital ICU, you may recognize this. I've not read this in medical journals, but this is an observation and I coined it a cycle of inappropriate weaning. So the patient comes in with the acute pneumonia, put on a breathing machine. On good days, you try to cut the support, cut. Then on the bad day, they go back on full support and so on and so forth. So I think if a patient is trapped in this cycle, like the polio patients in Copenhagen were trapped, then they needed medical students to help them, right? If all you have is the hospital, then at some stage you have to say we will stop. We cannot go on in this cycle forever. Can we send the patient home? The answer is probably yes. I apologize, this is a Philips machine, so there are 3 or 4 main lines of ventilatory equipment. There are the Breas equipment from Sweden, ResMed from Australia, Philips, of course, you know, it's a Dutch. Then China may have some ventilators. So I don't have any financial um, relationship with any of the companies. But if we can offer breathing support at home, then they may be able to go home. It's just like if you can offer a walking aid or wheelchair, then you give the patient mobility. So ventilation in a chronic setting is a breathing crutch or a breathing wheelchair, quote unquote. Okay, it's expensive. So in Singapore, the government partially subsidizes. If your government doesn't subsidize, would there be possibility of charity subsidizing so that families do not have to foot the bill? But on the other hand, I think it's important to realize that we are not obliged to receive every treatment. And remember, we talked about how treatment that prolongs survival inevitably leads to the increased suffering that comes from the disease. So I think we need to think through very clearly in our mind what is the correct treatment for each patient, and it's different. So we all have a duty to our loved ones, to our parents, to our spouse, to our children, to try to keep ourselves healthy and stay alive. That's a human duty. For those of us who are Muslim or Christian, we owe our life to God. And then, we have to look after ourselves. But are we obliged to empty our bank account so that we stay alive? Are we doing that is that action a good action for my parents, my spouse, and my children? I think this is something we need to be realistic and understand. Okay, well, I know the few vendors whose names I saw, I think they are very good and honest vendors. Okay. So, but everybody plays a part because this is a horrible disease. Okay. Okay, let's say I'm not advocating cutting corners and using cheap equipment, because there are certain requirements for different stages. So like in Singapore, we tend to follow the European recommendations that if you are more than 16 hours on the ventilator or you are ventilated through a tube, we'll use a certain grade of equipment. Whereas if you are just needing non-invasive and for shorter periods, we use a lower grade. So my appeal to the vendors in the audience is, regardless of where you are, be ethical and be charitable in your dealings with the ALS patients, and offer the correct, appropriate equipment. Don't take risks and offer cheap equipment that may harm the patient, and don't offer things that are unnecessary, extraordinary, that just burden the family. Okay, this schema I received from Dr. Douglas McKim. I will go through it in more detail when it's time, but essentially this is like a patient with breathing muscle weakness. They go from at risk to, these two may switch places. Some have problems with breathing and sleep, some have impact cough, and then the end stage is that most of them will need breathing support even in the daytime. So the question, these are the red ones, are the interventions that will dwell with in future sessions. The question is, do you need to give all of them? What are the benefits and what are the limitations of all these interventions? Okay. Okay, this is a Christmas slash New Year greeting from our patients. Our patients are very game. They try to advocate for themselves and each other. So we actually collected New Year greetings from them, and I think there's a problem in the video, so you may not see him, but you can hear his voice. So that is the patients helping to do their part to increase awareness.
Happy New Year.
Okay, I'm glad the video didn't disappear. Okay. This is another patient with who was admitted, and then he needed a tracheostomy.
Hey everyone, 2020 has been a tough year, especially so for us, the vulnerable ones. And to all my home ventilator users, hey, we've been through a lot. So stay strong, stay positive, and happy 2021.
So I'm very,
Hey,
very grateful to Riz for giving such an upbeat message to all the other ALS patients. I put this slide here, pardon the typo here, mobility, not mobility. I put this to show that it is perfectly possible to speak with a tracheostomy. We will dwell on this later. Whether you can speak or not depends more on the disease than on the tube, okay? But without denying the fact that with a tracheostomy, the care becomes a little bit more complicated. With the tracheostomy plus a life support ventilator, the cost of care goes up. So we will explore this in more detail in future sessions. We have published only to date one audit. So this is our 7-year retrospective kind of study. Thank Dr. Tan Gek Po plus the nurses for the hard work in assembling this data. And essentially what we see is self-evident. If you have motor neuron disease, ALS, without a ventilator, you will pass away faster. So this is cumulative survival. Um, so you see, without ALS, a lot of the patients will only survive less than 2 years. Whereas you put them on a ventilator, they survive much longer. So a lot of these patients started with non-invasive, and then they make a decision to switch to tracheostomy later. just remember that for this increased survival, if you live longer, you may live longer each day in misery. If you quarrel with your spouse, if you're a monster to your kids, or you may actually be very happy because you are very grateful and appreciative, and every sunrise and every flower that you see is a blessing. Okay, so I feel that as doctors, my job is to help them to live longer, but I also need to be a human being and help them to live better. And again, back to financial and other issues. So in Singapore, the government subsidies are present. So I've actually had rubbish collector who went on continuous non-invasive ventilation. So he went on this trajectory rather than this. And he had very poor family, only one spouse and one son, but his siblings came and helped look after him also. So he lived an extra 1 year and 3 months and passed away in peace, happily, and his family was very happy. But for one person like that, we may have 2 to 3 who have families torn apart, quarreling, and upset. So doctors and nurses, your job is not just to put them on life support. You know, we have to help our patients and family to live well. So having a longer life means that there's a responsibility to live better also. Okay, I think Dr. Low and the speech therapists will cover nutritional support, so I won't delve into it in big deal, but just a teaser. So this is a gastrostomy. This is a picture of a gastrostomy problem. So there's a Barrett bumper syndrome. This one shows our multidisciplinary team. So we have radiologists, we have a respiratory therapists, we've got nurses, radiographers, and myself, I'm taking the photo to help a patient safely access a radiologic gastrostomy. We'll talk about this when it's a correct session. Okay, when you live longer with ALS, you will have a lot of other symptoms. The most irritating to a lot of patients is the drooling of saliva because it's seen as like not dignified. You know, you have saliva drooling, you may have to wear a bib, and then you may have a rash around the face. It is uncomfortable and it's not dignified. So there are people who get almost suicidal about it. There'll be treatments, and I'm sure Dr. Low will be able to advise. But I think at this point, I'll say that sometimes dignity is our mental construct. You know, so it's a pride. So if I'm a bodybuilder or a actor and something, I always look handsome. Then when I don't look so good, I feel that I'm nothing. So I'm inspired by people like Stephen Hawking, who doesn't give a damn about his appearance, you know, and he goes on to continue to solve physics problems, write textbooks, and do whatever. So the dignity is in our mind. But the people around also have to give the patient dignity. So do not be squeamish, do not be scandalized when the patient drools. Okay, but there are certain treatments for siluria. We will discuss that in the future sessions. There may be pain, joint pains, muscle aches, sometimes contributed to by spasms. There will be constipation and urine issues, okay? And all these need to be discussed, so they will be talked about over the coming weeks or months, okay? Again, all these are seen often as undignified. I've got a lot of 50-year-old patients tell me, I don't want my daughter or my son to help me change diapers. So my answer to them always is, you change the diaper for your kid. Now it's time for you to graciously accept them changing diaper for you. You know, you have a responsibility now as a family member to receive love, not just to be giving. Okay, mobility, again, I'll leave it to someone else to dwell on the correct strategies, but preventing falls, allowing them to go around in the house or out of the house, how to choose a wheelchair, should they use a motorized wheelchair, how to prevent injuries, and so on and so forth. Communication, very cute. This is one of my first patients. She lived about 10 years. Initially, no ventilation. She changed her mind. So initially, she said, if I cannot move, cannot breathe, let me go. But along the way, she changed her goalposts. So she accepted non-invasive, then tracheostomy. She's very clever, so she figured out how to use a letter chart. And this is one of those old metal plates. On her thumb, she tied a little bell so she can tap with her thumb. So with this simple device, she could actually communicate sentences. She'll write beautiful, inspiring stories for other ALS patients. Of course, now I alluded to in KL and in Singapore, we have got alternative and augmentative communication. So this needs the eyes to be tracked by the machine. So with that, you can communicate and you can surf internet. So other experts will talk about this later. I've been alluding to this all morning, making sense of the illness and of life. So every time I see a patient, they'll say, why like that? Life has no meaning. And as a doctor, I really have no answer for that. It's true. ALS is a horrible disease. So sometimes I just tell them, are you sure? I say we can't choose our disease. All of us will fall sick and die. And all of us have the kind of like the mission to cope with our disease as best as we can. So is a stroke any better? Is Parkinson's any better? Is liver cancer any better? So I use this to try to change the topic, but I really have no answer. But our patients need to accept the diagnosis. They need to grieve the loss, and then they need to find out that they are still husbands, fathers. One of our patients, now he's found a new mission. I'll disclose more when the mission is accomplished. Used to be an engineer who helped build one of the most impressive dams in Singapore to prevent flooding. Okay, but now with ALS, he took a big hit, and then his personal sense of self esteem was hit. But now he found his new mission, and he's doing a fantastic job. They can still be friends of each other. So our job as professionals is how to help our patients find meaning and courage to face each day, and how to help their loved ones to cope. So on this, the common mistake of doctors, nurses, and therapists is that we are perfectionists. We say you must do this A to Z. Okay, no, you cannot suction that way because it's dirty. You must put on this glove and do this. Then we burden the family with impossible tasks. They are not here to take a nursing exam. There's no nurse educator checking off tick box. You got to prioritize what is acceptable standard of care. Because would you rather the patient die because the relatives or caregivers run away? Or would you accept a lower standard of care whilst we continually try to help them improve? So we are coaches of the family. We have to coach them on what is the ideal correct thing, but we have to accept their limitations, right? So this is something our whole team struggles with. Maybe my nurses can share a little bit more about this when it's their time. Okay, when you survive ALS, so like in Singapore, you may live 1 year to 3 years with ALS. You will have other diseases, accidents, stroke, heart attack. You may get infections. So we are discovering that we need to network with other professionals, with radiology, with endo center, and so on and so forth. But very importantly, the question comes up, if you now have bleeding from the stool, it could be colorectal cancer, should you go for scope? Should you go for surgery? Should you go for chemo? I think these are questions that need to be asked and answered, and there is no correct answer. So I hope Dr. Loh will be able to touch on this, on the decision-making aspect of this, while I may be able to touch a bit about the networking of this in future sessions. Okay, and of course, we have talked about how living and dying, the choices affect how long you live, may affect how you live and how you die. Okay, just a bit of sharing for my team. So this is Nurse Lydia. This is her at a community hospital, teaching nurses and physios in the community hospital how cough assist and how ventilation works. So obviously these are not lung specialists, they are not anesthetists. They have to absorb the knowledge and skill in a simplified way. We have to tease out what is essential and what is not important. Okay, so when you professionals in KL or Jakarta or Surabaya form your nucleus of expertise, then you have to go out and teach. And you have to create the criteria of what is essential and then teach it in a way that is effective. So we are still learning. We are grateful that we have this opportunity to continue learning here. All right. Okay, we are also quite a fun group. So during Christmas, we will perform and so on and so forth. Try to do things together with patients to entertain them. That is very important. We network with other professionals. Our hospital senior management is always a conflict because they think that we're doing a good mission and they try to encourage, but they worry about bottom line and they try to make us more efficient. So how do you do that? Then lastly, for people like Dr. Low, you're the team leader. I struggle with this every day. How do I keep my team close knit? How do I keep everybody's morale up? How do I make sure that each of us come to work and we see in the patient and the family a human being and not just an annoyance, a job to be gotten over? So if you all have any tips on this, please share and help us to grow also. One question for the KL, maybe Kuantan, maybe Kota Kinabalu, maybe Surabaya, is where will you choose to encounter your patient? So if you go to Europe, most of them are clinic-based. They'll have a huge multi-D clinic. Patients come all the way there, may live in a hotel for 2 days, and then they see all the different specialists there. Will this work in Singapore? Maybe, maybe not. You know, I've also visited chronic hospital wards in London. So a facility-based kind of setup. In Singapore, we kind of copied Newcastle in Northeast England, where the team goes out to the family. So we bring care to the home. So this is me. I actually, my nurse carries most of the things. I'm just bluffing only. But we carry a medical luggage trolley bag. These are our consumables because during COVID, we have to wear all the PPE. This is the blood gas machine. And there's a haversack behind with a computer inside plus more medical equipment. So I took this photo to show the heroic aspect of my nurses. They may go out alone, one frail girl carrying all these things. But that is what happens when you bring care to the home. Okay. How do you prepare a patient to go home? I think we'll need a session on this later, but just some teasers. So this is during COVID. Lydia doing a Zoom training for a family in another hospital. So, you know, the family members have to learn how to do tracheostomy, suctioning, how to respond if the tube drops out, how to respond if the ventilator fails. So there she is Zooming with the family. And then Lydia also very creative. There's one patient who is very nervous, don't dare to do rescue breathing on her loved one. So she invented this artificial lung. So what my RT calls this Mary, I call him Gary. So 2 lungs with gloves, and then the family member can practice, and then you can coach her and say, okay, don't hyperventilate, don't breathe too fast. Okay, you need to give more expiratory time than inspiratory time. 1, 2, 3, 4, 1, 2, 3, 4. So we'll figure out how to prepare the patient to go home. There's a lot of training. We need to make the training human and doable, not too high, but we must communicate safe things, right? Okay, so when I started in 2010, we didn't have a system. So asking the patient to go home was like that. It's like asking them to walk the plank. So over the 10 years, grateful to our team, we have figured out how to support our patients. This is just to show you the patient that Lydia trained. He was from another hospital. This was one of the first home visits. So you notice that he talks quite clearly. He presented with a pneumonia, and then the motor neuron disease was diagnosed subsequently. He's affecting mainly the breathing muscles, but his arms, core, and the voice are still strong at this stage, right? So different patients have different presentations. Okay, for the doctors, this is your homework. This is an old reference, 1999 from American College of Chest Physicians, mechanical ventilation beyond the ICU, published in Chest. And then this one is a more recent guidelines from Germany, German National Guideline for treating chronic respiratory failure. So those who want to learn about breathing, these are your homework. I'm sure Dr. Sheila and the neurologist and Dr. Low may have other homework for you. But please, you need to learn more, educate yourself. I end with this picture. So this is one of my favorite movies. Italian movie about a family. So this guy is a Jew, so he was discriminated against. This is a rich Italian lady. She fell in love with him, and then she left her family to marry him, and then they ran away from her parents, essentially. Then when the Nazis moved into Italy, the Jews were supposed to be rounded up, and then they went to a concentration camp. I encourage you to find the movie and watch it. It's very touching. There is tragedy at every scene, but this guy, this lady, and this son managed to make something beautiful out of every tragedy. So you will finish the movie with wet eyes and a smile. And I think that is what we try to do for each of our ALS patients. Every day is tough, but we try to finish each day with a smile. Okay, I think that's all. Thanks for listening.